out, but we are back. Thanks, Kelsey, for I can't even remember what I was saying, but let me share my PowerPoint first. Yes, your questions were lost. So if you feel your question has not been answered, please post it. And I'm saying before, the timing for the vaccine depends on the country's prevalence for measles, and also what proportion we think is still protected, but you don't want to give it too early because if the maternal antibodies are still present, they might neutralize it. This is supposed to be a break, although you already took a break. Can anybody guess where this is? It's at the border of Kenya and Tanzania. This will also give a chance to the other guys to log in. I think we've gone down from nearly 260 to 130. Zanzibar, Zanzibar is nowhere near the Kenyan border. Well, it's near, but it's not on the border. Somebody's talking about, maybe I should answer them first. Why not give the vaccine after 18 months? Yes, you can give after 18 months, but the question is, not all babies will get to 18 months. You lose many babies in between if you wait until 18 months. That's why I gave the example that countries like the US will give the vaccine at 12 to 15 months because measles is not so common, but we start at 9 months because measles is more common here. And we know many of our babies will still not be. Remember, 85% of the people who get the vaccine, babies who get the vaccine at 9 months will become, the vaccine will work. So if you wait for 18 months, it will mean these babies would not be protected for that extra 9 months, and you will lose some of them to measles. So this is now public health programming. Namanga, Lake Jipe, Lake Victoria, Lake Chala. Gabriel Chawana, this is right. Congratulations, I should buy you lunch for being woke. This is not Meru, not Arusha. Yes, so this is Lake Chala, a crater lake, very nice crater lake at the border of Kenya and Tanzania in Taita Taveta County. If you want to go to this place, you have to go through Oloitoktok or through Taveta. Can two competitive viruses of different families having same body targets merge their viral genome to produce a hybrid form? It's highly unlikely because they are different species, but when you have similar viruses, like we gave the example of influenza in the same cell, then that can happen. But if there are two different viruses, it's highly unlikely because they will not, whatever, the genome cannot merge because it's not the same. Okay, Frank, there's a Meru in Tanzania, so don't be kind. Mugambi, I know you're probably referring to Meru in Murega Mbaishu's county, but there's also a Meru in Tanzania, but this lake is not in Meru. Okay, I hope that motivates you to go and see that lake. You can even swim in there and row a boat. We move on to mumps. I see some people may still have challenges in joining. I hope they'll be joining. We are we've lost about 100 people. But mumps, although similar to measles, is different, and we'll see how. Remember, measles was morbillivirus. This is a rubella virus, and it's called mumps orthorubella. Although if you just say mumps virus, we understand you. Genus is orthorubella within the family Paramyxoviridae. I'm repeating that just for emphasis sake. And it causes a self-limited acute viral infection, meaning most of the times it will not cause a lot of harm. The main presentation of mumps is inflammation of one or more salivary glands. 90% of the time it will be the parotid glands. Could be bilateral most of the time, or it could be unilateral. And in about 10% of the times it will affect other salivary glands. Humans are the only hosts, which again is a good thing, meaning eradication is possible. And there's no cross-immunity with other paramyxoviruses. So because you got measles, you're not protected from mumps. And that's why even the vaccines are different for mumps and for measles, and even for other paramyxoviruses. This is the structure You can see also very simple with a linear genome that is protected by a capsid, also attached to the polymerase, which is the L, and the P, which is a phosphoprotein. Remember, the P phosphoprotein is important in replication, forming the replication complex. We call it the replicase, as well as immunosuppression. This is brown proteins are the matrix M, and then the envelope, which is the light blue one, has studs or glycoprotein structures. Hemagglutinin neuraminidase as the attachment glycoprotein, and fusion protein. So you can see in this case, unlike for influenza, the hemagglutinin and neuraminidase function, or HN protein, is actually one. It just has two functions. It can hemagglutinate or can cause a hemagglutination of RBCs in vitro or in the lab, not in the body, again, I insist. And it can also lyse sialic acid. So this is different from measles, because measles only has the H function. Mumps has both H and N functions. And then the fusion helps the virus to spread to nearby cells by fusing the cell membranes. I see here a few more questions. Okay, there are some people who are waiting for help to go to Lake Chala. Help Bikisha, please don't blame me. Transmission is via droplets or basically inhalation or direct contact. So maybe direct contact, then you touch your eyes or your mucosa. Incubation is 2 to 4 weeks, so slightly longer, almost double the period for measles. Remember, measles was up to 14 days. And it's very frequent in children aged between 5 and 9 years. We think before then there may be some maternal protection, but also there could be other epidemiological reasons. It can also occur in adolescents or younger or older children and adults. And the manifestations are slightly different for these groups. The clinical features are initially non-specific with fever, and usually it's not a very high fever, myalgia, headache, and malaise. And there's a swelling of the parotid gland, which can be, and the parotid glands are the ones just on your cheek, basically. It can be one-sided or both sides. And other salivary glands may be affected in 10% of the cases. This usually resolves without sequelae. I remember suffering mumps when I was, I think, nursery school or thereabouts. And because I was in the countryside, I was told to wake up very early in the morning and go chant some chants next to a tree. I don't know if it worked, but it was an interesting, very painful experience. I don't think I ate much that day. Occasionally, complications may occur, and these complications, this is parotitis, as you can see, the swollen parotid gland, diffuse, painful swelling. And the complications include encephalitis, especially in the younger children. You may find encephalitis, but it's rare. Deafness may occur. Otitis, which means inflammation of the testicles, which is closely associated with ophthalitis. It may occur in especially younger males. These are people who are in adolescent or young adults, not usually in children. Neuritis and myelitis may occur. GBS, which is usually a flaccid ascending paralysis, basically a weakness or paralysis of the body, beginning with the feet, then the legs, then the rest of the lower limb, then upwards. Myocarditis, pancreatitis, arthritis, uveitis. So you can see a lot of other systems may be involved. Diagnosis is very similar to measles. You have clinical features, you have specimen, usually saliva, because remember this, a lot of it is in the saliva. Urine, CSF, or blood may also work. Serology, antibodies, remember you look for antibodies in blood, unless you're looking for IgA. IgA antibodies may be found in the mucosa, so maybe saliva can give you IgA. Hemagglutination assays, remember this virus also has hemagglutination surface glycoprotein. So you can do hemagglutination inhibition assays like we described with the with the influenza, and you can also do PCR. Just to emphasize again that when you're doing serology, if you want to do diagnosis by testing for a viral antibody, IgG, remember IgG antibodies, a single one is not enough because IgG indicates previous exposure. The only way you can confirm current exposure with IgG is by doing a paired, meaning one, and then repeat it after 3, maybe 1 week, and then see if there's a 4-fold increase. If there's no increase in the titers, then that does not mean any infection. Management is not specific treatment. There's a vaccine, but it's only available in less than 60 countries. So even in Kenya, I think it's only available in private hospitals, not given routinely for everybody. And it helps if we can give it. I would like at this point to see your comments on the chat. What would you be most worried about if you are treating a child with mumps? What is the one thing you'd be concerned about from what you've described? I'll continue to read the messages as you post. One is phosphoproteins cause immunosuppression and phosphoproteins. So phosphoprotein is that one of the proteins found in paramyxoviruses, especially measles and mumps, like we've seen. And the first or primary role seems to be in replication. It works together with the polymerase to effect replication of the genome, the viral genome. But it also has an effect on the immune system, and which is immunosuppression. Myalgia is painful muscles or muscle pains. Sequelae means like if you are sick today from, say, some infection, but the infection is cleared, but there are other issues that come after that. And this could be anything. We've seen long COVID, where people get memory loss, they get a chronic cough, they get very many issues. That is sequelae. We see a lot of this even with the CNS infections, where you clear the infection, but because maybe you had brain death, the sequelae is still there. It could be in forms of speech impairment, movement or motor, memory, and other things. What does otitis occur in mumps? Does mumps have tropism? Yes, most of it seems to be associated with vasculitis, but it can occur. It does seem to have a predilection for the testicles and also the ovaries. Why is aseptic meningitis due to mumps more common in males than in females? No idea why. Maybe you can tell us. Damaging facial nerve when treating? No, I don't think so. That rarely happens. Even if you have Bell's palsy, it will be short-lived. Can otitis lead to infertility? Yes, it can. So that is a concern. Deafness is a concern, but it's rare. And even infertility is rare with mumps, but it can occur. Does the person with encephalitis due to mumps or the virus get well after it? Encephalitis, yes. A lot of times they get better. They self-limiting. What is oophorytis? Oophorytis is inflammation of the ovaries.
Oophorytis, yeah.
Okay, so thank you very much for that. I'll move to the last short virus presentation, which is rubella. I know some of you have requested to go for prayers by 12:30 and we'll finish by then. Also, I don't want to speak for too long. I know you guys will get tired of my voice. We are with you today for quite a while. Rubella was previously actually in a family called Toga viridae. Toga is, I think, Latin for clock, meaning envelope. It's not clock, clock is kujifunika. So this classification of rubella was done, I think, 2 or 3 years ago to Matona viridae. Matona sounds like a guy from Bongo Flavor, but it's actually a chap who differentiated rubella from measles and scarlet fever in the 1800s. It was called, I think, Greg Matton or something. So Matona viridae is the family. It only has 3 viruses. It's a new family with only 3 viruses, and the other 2 don't infect humans. They infect, I think, bats or something. So this is the only virus in this family that we are interested in, and it's called in the genus Rubivirus, and it's called, the full name is Rubivirus rubella with an E, Rubivirus rubella, and it's sufficient for you to call it rubella virus. We don't need to get into this technical bit or that. So I think we are very functional in terms of classification in virology. That's why it's very fluid. It's unlike, remember, paramyxoviruses like measles and mumps have a negative sense RNA. This one is positive sense, but it's also single-stranded and is also RNA, and it's also enveloped. So the only difference is that it's positive sense, while measles and mumps are negative sense. Transmission is also the same route, respiratory or direct contact. And there are two main entities. One is postnatal rubella, which causes mild disease. So all of you right now, if you get rubella, you'll be okay. But if you're carrying a baby, especially in the first 12 weeks, then we are worried about congenital rubella syndrome, which can be quite severe. So if any of you get sick with rubella right now, it wouldn't be such a big deal. But if a child is infected in utero, or a fetus is infected in utero, especially within the first 12 weeks, it's likely to be disastrous. Actually, rubella is the leading cause of stillbirths, or thought to be the leading cause of stillbirths and abortions across the world. The structure is quite simple, as you can see here. This is what we call an icosahedral capsid, basically 20-sided equal sides. And this is a linear genome. The RNA genome, as we said, which is single-stranded, positive sense. And then there's the envelope, which is, I think you may not be seeing my cursor. Let me get it. So as I was saying, this is the genome, which is linear, although you can see it is quite irregular, but it's just a linear genome. The capsid here is what we call icosahedral, not a big deal. Then there's the envelope, which is this bilipid layer, and the studs, or the surface glycoproteins, are E1 and E2. E1 is like, if this is a matchstick, the head is E1, E2 is the stalk. And actually E1, it has hemagglutinin activity, interestingly. So E1 can hemagglutinise red blood cells in vitro, not in vivo, not in the body, but on the bench. So it's a very simple structure. You can see this virus only codes for 3 proteins: the capsid protein, E1 and E2, and then of course the non-structural enzymes. The pathogenesis is that after entering through the respiratory mucosa, you have incubation for up to 3 weeks. And then there's during this period, there's local invasion in the respiratory mucosa, basically infecting the cells of the respiratory mucosa with primary viremia, leading to the reticuloendothelial system. This reticuloendothelial system is really, I would say it's like the macrophage system across the body. It's where you will find in macrophage systems, macrophages in the skin. You'll find them in the liver, we call them Kupffer cells. In the spleen, we call them macrophages. In the brain, they have a different name. In the kidney, they have a different name. So they're almost everywhere. So that reticuloendothelial system is the first place where the virus replicates. And then there'll be a second, more marked viremia, because now there has been more sites for replication. And the second, more marked viremia, which occurs up to 3 weeks after this infection, then will disseminate the virus to all the other organs, including the skin and other mucosal surfaces. And the rash on the skin is also immune mediated. The rash we see on the skin is also immune mediated. The features of rubella are non-specific, and they include fever, anorexia, headache. In fact, the younger children will not even have this. And you may have some people with pharyngitis, conjunctivitis, tender lymphadenopathy, especially at the posterior triangle of the neck, just around the area below the occiput. Tender lymphadenopathy, meaning there are lymph nodes that are swollen and they are painful. The Forsheimer sign, and this can be contrasted with Koplik sign. Koplik sign is in measles with the buccal cavity lesions. Forsheimer sign are like pinpoint lesions on the roof of the mouth. This is the soft palate, where you find basically the rash, pinpoint red spots on the soft palate, or basically in the roof of the mouth. And the rash in the body is generally similar to measles. You cannot tell it apart, although it tends to last shorter. In fact, some people have called rubella the 3-day measles. The rash is still maculopapular, it's centrifugal, meaning it starts from the face and spreads downwards, and it will disappear in 3 to 5 days. This is the, although not so clear, but you can see the spots on the palate. You can see the maculopapular rash. And so this sign is called the Forsheimer sign, typical for rubella, but I think it's in very few people. You will not see it in many of the people with rubella. I think it's probably 20% or so. And the maculopapular rash, which is very, you cannot distinguish it from measles or even mumps unless you test. But out of the epidemiological understanding, many times when you see this, we prioritize measles because it's the, I think, more riskier of the three. This is also a generalized maculopapular rash on a lighter skin. Complications for postnatal rubella, and this is to differentiate it from congenital rubella. You have in younger children encephalitis. In adolescents and basically these are, we can call them older children and adults. You could have arthralgia and arthritis. This is especially more common in women. And you can also have thrombocytopenia presenting with papilla as well. Congenital rubella syndrome is something you need to keep in mind. It's one of the reasons why some of these vaccines we give to women only, and then the church is here wondering why we are only giving women, whether we want to sterilize them, and really we just want to protect their babies. Congenital rubella syndrome is very likely, especially if infection occurs during the 12 weeks, the first 12 weeks of pregnancy. And usually this will occur when the mother gets infected with rubella and during the high viremic phase. Remember that there are two viremic phases, especially the second one, where the virus is disseminated everywhere. It can get into the placenta and cross into the baby or into the fetus. And once it does that within the fetus, it doesn't seem to have any immune response at all, but it seems to kill or destroy fetal cells through necrosis, which is vasculitis related. And also it seems to inhibit mitosis. And remember, there's a lot of cell division in the fetus. So when you inhibit mitosis, what you're inhibiting is actually organogenesis, especially early in the pregnancy. So eventually what you end up with are congenital malformations. The commonest are these three: microcephaly, congenital cardiac disease, which is called, the most common is PDA or patent ductus arteriosus, which is basically just a hole between the aorta and the pulmonary artery. And remember, pulmonary artery is bringing in unoxygenated blood and all that, so it will interfere with the lung function and the body. The heart may get worse, and the child, if the PDA is severe, the child may die. If the PDA is not so bad, some of them you can even live with it, and others can be corrected. Cataracts, basically in the eye, and these are the common but not the only presentations, meaning you can have other complications in the eyes, other complications in the heart, other complications in the brain, and even in other systems. I think I've listed them here. Let's see. Yeah, the other common symptoms actually are sensorineural hearing loss, which means deafness in 60% of the patients, ocular abnormalities, and these include not just cataracts, but also glaucoma and retinopathy. You can have cardiac abnormalities, which will fall in the category of congenital cardiac disease, with the patent ductus arteriosus, pulmonary artery stenosis, and a few others. You can also have abortions and stillbirths. The difference between these two is when the loss occurs. If the pregnancy loss is occurring very early before the baby becomes viable, it's called an abortion. If it's after the baby becomes viable or is considered viable, then it's a stillbirth. So it's the same thing really at different times. You can have mental retardation, you can have hypotonia, you can have microcephaly or cephaly or encephalitis. All these can occur. And you can see hepatosplenomegaly, anemia, thrombocytopenic purpura. You have endocrine effects, including diabetes, thyroiditis. All these can occur in a child. And so the reason we insist that right now we are giving, I think, every child in Kenya measles and rubella vaccine, but before we were giving it to women also and girls in the reproductive age group so that we protect their babies. So really rubella for adults or for people who are already postnatally is not a big deal, but if it occurs when you are pregnant, then we are worried about the fetus. Diagnosis, the main thing is clinical features. This is especially for congenital rubella, and you can test these different specimen. And for congenital rubella, actually, the baby can continue secreting the virus for up to a year after they are born, because there is not really a functional immune response against rubella at that point. You can also have other other samples or specimen like nasopharyngeal swab, depending on who you are testing, urine, blood, or cord blood if you're suspecting a newborn has CRS or congenital rubella syndrome. Serology is very similar to measles, IgM, or paired IgG. And even here, you can do ELISA, immunofluorescence assays, you can do hemagglutination inhibition, because if you remember the surface structure E1 for rubella has hemagglutination function. You can also do PCR and viral culture, although these are mostly cultures are mostly for research. So for management, really supportive, not more specific antiviral therapy, but we have a vaccine which is live attenuated virus, either as single or as in combination with measles, sometimes in combination with measles and mumps, or in measles, mumps, and varicella, and a lot of health education. I just mentioned in passing that previously we had resistance when you say you want to vaccinate girls and women, because there are many people now who never received Ebola, and when they get into start making babies, you need to protect them. And the best way to protect them is make sure the mother is protected, because if the mother is immune, then they will not get rubella during pregnancy, and so the child will not get congenital rubella. But a lot of times when you say a certain measure is only targeting girls only, there's a bit of suspicion. Do you want to make our girls sterile? Do you want to do this or the other? So health education comes in handy. So don't dismiss such views. Take the opportunity to educate yourself so that you do not perpetuate the same views erroneously, and you can actually answer them authoritatively and correctly. I'm sure by now you realize that for most of you, you are the go-to resource, medical resource in your families and in your circles. So before we finish, I would like you to answer 2 questions. We still have time, I think. I will not break my promise of finishing before, after 12:30. So I will read at the comments as you answer, and look at the comments as you answer this question. Which of the following is least likely to cause bilateral conjunctivitis? This one you might need to think slightly outside the box, but it won't hurt to do so. Okay, so I see some crazy chap here or girl is asking whether we can use rubella for abortion. No, it may not even cause abortion, so you will end up with a child who has congenital abnormalities. Could we get electron micrographs of these viruses? You can just Google them up, but I didn't put them up here because I didn't think they were going to help you in differentiating them. Usually I post electron micrographs when there's something specific I want to show you. Class 4, I don't know what class 4 means. Baltimore class 4. Oh yeah, this is single positive sense, single-stranded RNA virus is class 4. The first class of Baltimore is double-stranded DNA, then single-stranded DNA, then double-stranded RNA is class 3, single-stranded positive sense RNA is class 4, negative sense single-stranded RNA is class 5, then there's class 6 and 7, which have a reverse transcribing component, 6 being DNA and the 7th being RNA. I'm still trying to look at this comment, but these things keeps going up. Mumps and rubella are helical. I won't get into that. I don't really bother too much with the symmetry. Can dengue be transmitted transplacentally? I think you'll have a session on dengue. I would like to do that to the person covering it. But it's not such a big deal. Congenital transmission of dengue is not such a big deal. I wouldn't say it is not, but it's not a big issue. Zika is where we have problems. Rhinovirus. Oh, so the question here is that I see now answers to the question. The question, one of the following is least likely to cause conjunctivitis, and yes, as most of you have indicated, the answer is E. rhinovirus. Adenovirus is actually one of the commonest causes of bilateral epidemic conjunctivitis, and adenoviruses cause many other things. So I don't know if we'll cover it, but if you don't, you need to read about it. As far as cystitis or hemorrhagic cystitis, actually, to diarrhea, to pneumonia, to encephalitis. So adenoviruses are almost everywhere. Kip, please mute. We don't want to hear you doing interesting things. I'm still continuing with the charts, sorry. What are infections like varicella and mumps more severe? Why are infections like varicella and mumps more severe in adults compared to children? I suspect has something to do with the vividity or the strength of the immune response. The stronger the immune response, the more likely you have some of these issues. Why is it that even after getting measles vaccine at 9 months, one is told that you can get it, but only once in your life? Because once you get immunized, either through the vaccine or through infection, then the immunity is lifelong. But we say that at 9 months, some babies get the vaccine, but they don't get immunized because the maternal antibodies neutralize the infection. The lifelong protection comes from either exposure or successful immunization. So once that happens, then yes, you're protected. Somebody's asking why not adenovirus, and I indicated that adenovirus causes conjunctivitis. Who captured the link for books? Actually, that is a link that you can use for many things. It's just type microbiologybook.org. And I'm going to share these slides. Anyway, the link is in the slides. And the questions you asked earlier on why should we be worried in treating a child? Is it because of adverse drug reactions? Not really. I would be more worried about other things like encephalitis and infertility or deafness. But there's no specific answer for that question. I just wanted you guys to scratch your heads. The last question for today, one of the following is a true, a lot of grammatical errors today. One of the following, one of the following is true about measles, but not rubella virus. So does, basically which of the following is the difference between measles and rubella? Is RNA genome only in measles but not in rubella? Is a maculopapular rash only in measles but not in rubella? Is live attenuated vaccine only available for measles but not for rubella? And does viremia only occur with measles but not with rubella? Do Koplik spots only occur with measles but not for rubella? So which one of these is the correct answer? A lot of you have gotten it right. I see no wrong answers. Yes, the correct answer is Koplik spots. And with that, I would like to rest for now, and we can, let me just make sure, yes. There are a few questions in the chat. I think we can answer them, and then we'll meet again at 2. Hopefully we'll be done by 4 p.m. Does a child born with congenital rubella have lifelong immunity? No. Because by the time they are born, the rubella has already established itself in that child. They may not get infected well, but they will, and that's why they are secreting the virus for a whole year. They are going to have these manifestations for the rest of their life. Does RSV belong to paramyxo? Not anymore. It is now in a family we call Pneumoviridae. Pneumoviridae. So this has been reclassified. In your older notes, you will find RSV in this category called paramyxoviridae, but it's actually now in a family called Pneumoviridae. They are not, it's no longer paramyxoviridae. But you will find a lot of text still talking about that. Generally, for all viruses, what are the main things we need to focus on during revision? Family, pathogenesis, epidemiology, the things we emphasize in class actually, and you can see them, but there are those general things you need to know. The viral characteristics, which family, what is the genome, is it enveloped, is it DNA? The distribution sometimes is important to know. Roughly, how big a problem is it? How many people does it infect? Where is it found? We also need to know about the pathogenesis. How does it cause disease? The clinical features, the diagnosis is very important, and treatment. And the treatment, where there is specific therapy, you need to know about the mechanisms of the drugs. And a few other things like vaccines. And you saw some of the viral characteristics, or some of the viruses include antigenic variation and all that. We were told that Rubella virus has no visible cytopathic effects. So how do we perform viral culture? Thank you, Nango. So how can you, when you perform cultures, you don't have to look for the cytopathic effect only. You can look for other things, like the virus that has grown. First of all, is there a virus? And you can identify the virus using other tests. You can identify also with electron microscope, but usually using other tests. What topic, like PCR, hemagglutination, and all that. So what topic are we doing in the afternoon? We are covering ELISA and lateral flow assays, virology methods. If a child develops a rash after getting measles, mumps, and rubella, is he contagious? That's an interesting question. I have not seen cases of where the virus is mutating to become infectious. We see with polio occasionally, after many passages, the virus can mutate to become contagious. So for MMR, I suspect that they may not, but I need to confirm that, where there have been cases of measles, mumps, or rubella live attenuated vaccines becoming infectious. I haven't heard any reports. But yeah, this is medicine. You never say never. Lab methods, that was an answer. How can you prevent the maternal antibodies from utilizing the vaccine? You really can't. You just time when they are over, unless you want to do pharesis. you sort of filter the blood and get rid of the antibodies, which is, there's no point. Or get a vaccine that is not live attenuated, a vaccine that is not seen as an infection by the body as such. What advice would you offer to a mother who gets infected during the first trimester and the fetus? Well, for me, I think if the child is not viable, I would recommend a medical termination of pregnancy, which is also called abortion. Some people might have a problem with that. I do not. And there are very many ways of going around it. Okay, so I see those are the last questions. Oh, you asked this morning at the beginning, if humans are the only reservoirs for measles, why has it not been eradicated? Maybe Mugambi has a response. Could you tell us why? Why is it that we've not eradicated measles after so long? Maybe I'll let you guys Google that for the next 30 minutes for lunch. Mugambi, yes, I noticed you have offered an answer by asking the question. Okay, actually, even in the US, we do get outbreaks of measles. So this is not just a third world issue. So just check it out, Google it out and find out. Okay, I think I would like to stop there, or there are more questions. Why are we covering rubella under the family? Because they present this with similar features. Measles, mumps, and rubella are actually very difficult to distinguish clinically. And you see, even for hepatitis, we cover 5, 6 viruses that are in totally different families because they cause a similar disease. Similar, not the same, but similar. Is urine analysis used in diagnosing mumps? What do you have in mind, Christopher? How do you think analysis would help us in diagnosing mumps? If you are thinking of PCR or culture of the urine, yes. If you're just doing pure urinalysis, which looks at chemical and maybe blood contents in the urine, it won't be very specific. For viruria, yes, you can do PCR and you can do culture, but we don't do that much. Most of the time, when we see a child with mumps, we really don't need to diagnose unless you are suspecting encephalitis, in which case, why are you taking a urine sample, not CSF? So generally, we may not do those tests on urine quite a bit, unless you have taken several samples and you're testing all of them together and you're not sure what you're looking for. So sometimes we do that. Okay, I think we seem to have exhausted all the questions. Thank you for your attention and your engagement. I look forward to seeing you guys again at 2 p.m. I guess we should now say Juma Mubarak to those who are going to pray. Thank you very much.
Thank you.